Hi everyone, welcome to this evening's session in the QHSLab Optimizing Primary Care series. I'm Troy Grogan, the CEO at QHSLab. I'm glad everyone can join and be a part of this session. Today we're diving into a vital topic, especially for primary care teams, in recognizing and managing mild cognitive impairment and dementia, and especially early where we can still make some differences in our patients and families. So to take us into the discussion, I'm going to, as always, hand things over to Dr. Marcos Sanchez Gonzalez. He's our Vice President of Medical and Scientific Affairs here at QHS Lab. He'll give a detailed introduction, and he'll also introduce our expert special guest, Dr. Patricia Junquera. So Marcos, take us away.
Thank you, Mr. Grogan. Hello, everyone. Always glad to be here with you. Before we get started and I introduce our guests, I want to pause for a second. Because the other day we were having these controversies on AI and digital medicine and computers and machines taking over the world. But there's two attributes that, in my view, I don't think there's shown any way a machine will be able to replicate. They're uniquely human. Number one is consciousness. And number two is intentionality. Consciousness and intentionality. And why that is important? Because right now, as we speak, we have 1 in 5 adults experiencing something that we call mild cognitive impairment. 1 in 10 diagnosed with dementia. Almost 7 million people in the US is living with a very common dementia, or the most common of the dementias, Alzheimer's disease. And this number, it's going to increase to almost 40 million by 2060. For me, the way I define dementias, not medically, it's when the person ability for that intentionality and consciousness start to fade away. We're losing that amount of people. What makes us uniquely human is lost in dementia. What we can do about it? Are we have now the tools? Do we have the knowledge to make this better? Well, I'm not the right person to talk about that, of course, but we do have what we consider an expert in the area. Our guest today is Dr. Patricia Junquera. She is the chair of the Department of Psychiatry at the Florida International University, and she has dedicated her career to academia and clinical care, in particular, working with adults and geriatric populations that are affected by different behavioral and cognitive issues. And Dr. Junquera, first of all, thank you for being here. It's a pleasure to have you here.
Thank you for having me.
It's excellent to have you here, but I'm going to get close and personal very quick. What motivated you in the first place to start working with these senior populations that, as we know, they have these kind of cognitive impairment, dementias, and very specific disorders in this population?
So I think I always say psychiatry found me, and I was very open to finding out about the mind and why people feel the way they feel, depressed, sad, anxious, but more inclusive. I found out more and more as I went into training that I wasn't your touchy-feeling psychiatrist type, and that I was more of a medical kind. And so I like to see the patient holistically. And so I was drawn to subspecialties like addiction medicine, which is within psychiatry, consult liaison, which is in the medical floor, and geriatric specifically because of the drug-drug interactions, because of how different they react, sort of at the different spectrum of life. How children react to medicine is very different as well. I was more drawn to geriatrics because I was raised for 8 years with older people. My grandmother lived in the house with us, and she's one of 12. And so I felt very comfortable around older people.
Oh, it's an interesting story. And by the way, you know, when we have these conversations with, say, old people, many times they forget because they're old, and oh, poor, they don't process the same because they're old. But in reality, aging doesn't have to be a state of dementia. Normal aging doesn't mean that you're going to develop just dementia. And in many times, these might go undetected sometime earlier. In your view, in your view, what are those early signs that maybe 2, 3, 5 years before you start seeing or identifying these patients before they develop the full spectrum of any of the dementias?
So let me backtrack a little bit. There is no such thing as memory loss being normal. People think that as we age, we lose memory, and we don't. We lose agility to bring back memories and to think quickly. So that's very different than a memory loss. So I think the earliest signs of a functional, not just a memory related thing, is, for instance, missing a payment of a bill, going to the store several times and you still come back without the right things. Subtle changes in personality, like not wanting to go out, not wanting to engage in activities, not being able to remember the names of the medications they're taking, or not being able to see, you know, okay, this one's the one that I took this morning. A lot of times the family is not living with them and they don't notice these things. And so these are very subtle changes. I think one thing that always gets the family is when I ask, what do you eat every day? And they tell me the same thing over and over and over, because they lose the ability to plan a meal. They might say, I want to eat lasagna today, but they can't say, okay, I need this and this and this and this, and then go to the store and get it and see what goes first and what goes second. They lose that ability. And so that happens. That doesn't happen in normal aging.
Okay.
What I just spoke to about my grandmother, she's one of 12. There's 6 sisters that are still alive, and they're 107 to 95, the ones that are alive, and they're clear.
Wow.
So yeah, my poor husband. Yeah, I have good genes. So
we need to ask the prescription for that.
What about writing notes all the time? Is that a sign of memory loss? Like if you're making a list and
the problem is that then they leave the list.
Yeah, okay, yeah.
So so that's one thing. They carry a notebook with them. The problem is that they forget that they wrote it in the notebook. But there's a lot of different finances is one thing that for sure is one of those things that the family is not checking, and that aging adult appointments are another thing. They forget that they have appointments, and then the rest of their illnesses are not being taken care of. So as Dr. Gonzalez alluded to, that Alzheimer is the most common, it is often not genetic. So about 5 to 10% of Alzheimer's is genetic, and the other 90% is what we eat and what we do. And so it's really important to have the primary care doctor be at their very best trying to screen this, because it is preventable in many of the cases. And the other one that's the second most popular is vascular dementia. Vascular dementia has to do with medications, but if you're forgetting things, you're forgetting to take your meds. And if you have your meds not in a pill box, for example, then you say, oh, did I take it? oh, maybe I took it, or maybe I didn't take it, and then they take it twice. Or maybe they say, I took it, and then they miss 3 doses. Blood pressure goes up, cholesterol goes up, and these spikes cause microinfarcts in the brain, which cause the memory loss. So 2 big things, 2 big differences that you can tell right away. The patient with Alzheimer's or early Alzheimer's doesn't realize that they're forgetting things. They don't realize that they're forgetting things. They are brought in by a family member with concern. The patient with vascular dementia is still driving to your office, very upset that they're forgetting things, and they want me to fix it. But what they need to fix is the blood pressure, diabetes, and cholesterol.
Mm-hmm.
Okay. Okay. So you were mentioning all of these different symptoms and signs, and as part of a comprehensive medical history. But now in primary care, as you know, there's so much time we have in that medical encounter. So why do you think, among other, I mean, there's some systemic issues among other things, but the challenge in primary care, why many of these things like mild cognitive impairment or these early signs go undetected at the primary care level?
Why? I think that they're trying to do their best in 15 minutes, 15, 20 minutes. And so these subtle changes look like depression. They look like sleep problems. They look like other things that they mask the true decrease in memory, right? So do they have time to do a full cognitive exam? Obviously not. They don't have that time. And so what I think is that they focus on the bigger acute problems, right? Is there a pain somewhere? Is there problem breathing? Is there, high blood pressure? Any acute concerns?
Mhm.
And then they also are doing maybe a PHQ-2, and maybe that's positive, and they go the route of the antidepressant, which doesn't get them better. Because that lack of motivation and isolation is not depression. It's actually mild cognitive impairment or a dementia already.
Wow. Okay. So, because usually in primary care, you gave that example, PHQ-2. They rely on checklists or, okay, let me check this here, let me check that there. But then trying to isolate that problem, that symptom, maybe look into the root cause, okay? When you're accessing, let's say, memory, cognition, what tools, what tests you usually recommend or follow to get to that diagnosis?
So I work with an interdisciplinary group at FIU, Baptist Health. And what they try to do is a mini cog, which doesn't tell you much, right? But I think the more important things are for the primary care provider to identify any causes of reversible dementia, meaning thyroid problems, right? That decreases memory, B1, B9, and B12 deficiencies, that causes memory problems. And the B12 is super important because I've heard many providers say, oh, it's normal, and then it's 200. No, below 500, which is still normal, there is what we call decreased agility and problems with recalling even same day things. So you forget the line of thought, your thought process is broken, and say, where was I going with this? What was I saying? That kind of thing starts happening when the diet lacks red meat, when it lacks vegetables, when you're eating chicken all the time, which a lot of people do, trying to be healthy. And so I have to tell you that recently I have not had a B12 more than 500. I do that regularly. And it's very hard to find one in the thousands.
Wow. And
What
as you go ahead, Mr. Grove.
what's the immediate plan of action there? Is it, you know, supplementation, injection?
So as a primary care, I would supplement, because you could do the injection once a week, but there are studies that show that supplementation, sublingual or is exactly the same, as long as it's sublingual and it's daily and it's more than 5,000 micrograms. The good thing about B12 is that when you don't need it, it comes out of your urine. So you're not going to become toxic on B12.
Sublingual, so that doesn't matter, like before you brush your teeth, after you brush your teeth.
So, I always put it right next to the coffee, because I can't forget my coffee. So
Yeah.
I don't forget my B12.
Okay.
No coffee, no work.
That's
and with coffee, it's fine. What about with food?
No, I do it while I'm brewing the coffee. I
Okay.
put my tongue, melts right away, and then that's it. And then I do the rest of the thing. Sublingual absorption
Good.
is
Great tip. And then when do you remeasure? Is that 3 months, 6 months? What's the remeasurement period?
So I check it. I do a mini mental or a mocha on that patient. And if there's improvement, it was that. Usually, you know, when the patient notices themselves, they're very picky brains and very functional. I have a 90-year-old that says his memory is failing. A 90 that's memory is failing, but he's still working.
Yeah. Oh, good. Good for him.
He's still working. He has his own business, and he notices that he's not. So I worked with him, and he now understands that it's not the memory loss. He also has anxiety, and he also has decreased agility.
Well, while we're on this subject, Dr. Marcos, I just want to ask another question, like non-pharmacological omega-3. What's the psychiatrist's position on that in this same subject area? Is that another non-pharmacological assistant in this plan?
I think omegas or food with high omega content is imperative, just because of inflammation and it helps with vascular. And now we're seeing more and more that Alzheimer's is also a lot of inflammation, those beta amyloid plaques. So yeah, that vitamin E, 400 units of vitamin E is also very good.
So as I hear here and listening to you, I go into putting my head around different dimensions that you're mentioning here. So there's a biological, physiological dimension, lack of B12 or vitamin or a nutrient that is needed. And that nutrient might not be there simply because they don't have the health habits, the right diet, or they don't be taken care adequately because they don't have a caregiver or so on. So that's kind of a biological, but there's a social, psychological factor here. As you mentioned, that many of these conditions, they start expressing themselves not only as forgetfulness, but depressive symptoms, sadness, relief. So you go into that biological, but now you get into that more behavioral changes and issues. And as a psychiatrist, I'm pretty sure you have seen many of these. So what are those behavioral changes that they can be confused with? This is a depression or an anxiety or sleep issue, but also it's a manifestation or a symptom of the same cognitive impairment.
So there's different kinds of ways that we can tell that it's depression versus a dementia, anxiety versus a dementia or decrease in memory. One is doing the scales for anxiety and depression. HQ9, GAD-7 is what I use in my practice. But also the mini mental will not be greatly affected. So, and it would be affected only in the concentration part. So they can recall pretty well, but they cannot calculate, for example. They can repeat, they can recall 2 out of 3, but they cannot calculate. And both depression and anxiety have a decrease in memory.
Okay.
So,
So you have that biological aspect, I have behavioral, psychological aspect. And of course, there's some social aspects to it.
yes.
Coming from that school, I was trained under a social psychologist, and at the time I didn't understood as a physiologist that these things are not. But we do have to this day these social determinants of health, and they are called that way for a good reason, because they've been shown to be significant predictors of health outcomes. So now we
Right.
have these biological, psychological, and then into these social determinants. In your experience, what are the characteristics that we find this particular type of patient?
With the ones that have comorbid.
Yes, yes.
So there's a bit more. So there's a bit more of comorbid cases with the vascular dementia, because they are understanding that they're forgetting. With the Alzheimer's patient, it's not them. It's not them. It's the family that is getting affected. It's the caretaker. So very different things. But yeah, it's more on the vascular. I think the frontotemporal dementia patients also have issues with comorbid conditions, and because they notice a little bit more of a personality change, and they notice that they're forgetting things.
So we and using this too. So apart to the patient, what is the impact in that family and the caregiver? Are there's some measurable changes that you see in the family dynamics that are taking care of these patients that you can?
I think adult children taking care of parents is very difficult, because we all have our own everyday jobs and kids and responsibilities, right? And for a very long time, our parents were independent. And now we're seeing, I don't know if they can drive. I don't know what I do if they get lost. I have to go every Sunday and prepare their pills. What if they fall? You know, a lot of different things that we're really not aware of until something happens and we need to make changes. A lot of the times is changing that individual living space, and they feel bad about taking that away. Again, in different dementias, different way, right? Alzheimer's patient, you change them, you put them in another country, they won't know the difference. But in a vascular patient, when you change their location, they go through some depression, some inability to function on their own, and that's very tough for the family.
Oh, this is a triad of biological, psychological, and social aspects here. And earlier you mentioned that you're part of these multidisciplinary team, but in primary care, you are the multidisciplinary team. You have to pretty much do everything. You're the safety net. Let's say there's some tools out there that we provide, and we identify these patients. There's different programs in primary care level that we can use for that, like behavioral health integration and so on. At what point this care coordination referral starts to make part of the whole holistic care? When the primary care practitioners say, okay, I need help, okay, to manage or deal with this patient or direct this patient once identified?
So I think it depends on the provider and their level of training and confidence. I think most primary care providers will check out everything that they can reverse on their own, right? So thyroid, vitamins, they review the medication, make sure they're not on benzodiazepines that decrease memory. The good thing about benzos is that once you stop taking them, the memory comes back. It's not a permanent change. So that's something that they can taper off. There are some medications that make the brain a little bit more sluggish, like Lamictal and other anti-seizure medication. And so they have to do a good review of that. Once it goes beyond mild cognitive impairment, let's say to a 24 in the mini mental, I think they should be referred, because there are many things now that we could do that we were not able to do before. Before we gave them donepezil, galantamine, Namenda, and let's hope for the best, right? Now there's, a lot of different things that we can do for mild cognitive impairment that can maybe prevent the accumulation of beta amyloid plaques, like Leqembi and all of those other medications that are IV now, but they're eventually going to be go through the brain blood barrier with the use of focused ultrasound. So
Wow.
different things. This is already happening in some universities. We are doing one trial for Alzheimer's that we are opening the brain blood barrier with the focused ultrasound, and it recloses within 24 hours. So it is safe to do. It is a long procedure right now because we're using low intensity focused ultrasound, but this is already being used also for Parkinson's. Parkinson's dementia is also co-occurring with depression and the lack of movement. The Parkinson features that, that loss of expression in the face confuses people with she's depressed, right? And so I think it's up to the doctor, the primary care, and what they feel comfortable with. But honestly, I've seen a lot of patients that have been on donepezil 5 milligrams for a long time, and we could have done better. We could have taken them to the top. We could have mixed it with Namenda. We could have used a medication that they're both mixed in and use one medication instead of two due to compliance. So there's a lot of different things that maybe a specialist would know that a primary would be better off just doing, a more synthesized scale and not spend 15 minutes doing a scale. I apologize for my dogs. And so I would refer sooner than later.
Okay. In terms of tools, okay, and going back to what we're talking about, how we can identify the primary care level, okay? With the limited time we have, probably we can use other tools that, of course, we have developed some of those important tools. One of the ones that we have is QCOG, that have that biological, psychological factors, social determinants, and so on. And then the primary care level identifies and then try to address those reversible causes that you mentioned at the physiological level. Let me check your B12, your thyroid, and so on. And then if things get, to the next level, then escalate the care. Still, it's a patient in primary care. But something that is interesting to me is that at the population level, would you recommend that every single senior citizen coming through my door as a primary care practitioner should be evaluated at least once a year, twice a year, or just in selected patients? What do you think about at a population level?
You're on mute, Doctor.
Mute, yeah.
Dr. Junquera, you've gone on to mute.
Very sorry.
There you go.
I had to mute my dogs. So so I do think that we all need to be screened. I tell you why. Look, when we start extending our arm because we can't see the letters on the phone, That hasn't happened to you guys, right? Because you're young. But my arm is no longer long enough. So I could tell you there's studies that prove that the agility of the brain isn't as good as when we were 40. And so I think down the line, we will see a preventive screening, just like we do for cervical cancer, breast cancer, colon cancer. This is diabetes type 3, dementia.
Mm-hmm.
And we have to screen for it. Before, we thought it was just aging. Now we know that we can prevent it. You know, when I went to medical school, the only way of knowing that that the patient had Alzheimer's disease was postmortem pathology. And so now we have PET CT, PET scans, beta amyloid scans, and it's so much easier. It's either you have it or you don't. We have genetic testing, right? So there's the technology exists. I think we just have to screen with a scale rather than spend so much money prior to having identified a decrease in memory, and not have to wait until you are actually having problems with your ADLs.
Is annually enough, doctor, or biannually? What's your recommendation?
So I think at first we're going to do annual. I think that will be because you have an annual exam with your primary care, and most insurances mandate that. And
yeah, part of the requirements.
yeah.
Yeah.
And so I think at least it will be in the annual, just like the depression screen.
Okay. I want to talk about those biomarkers. No, you were mentioning some of the existing biomarkers that there are not many. No, compared to 20 years ago, yes, we have more, but still our best tool is to use written tests or digitalized tools, basically, or validated instruments to capture some of these symptoms. That's the best we can do.
Are using the biomarkers. I always tell them, don't send the biomarker without a PET, without a beta amyloid. Most insurances don't pay for it, beta amyloid. Patients don't have the money for that. It is not FDA approved way of diagnosing, and it could put the patient in a scare, and really it doesn't correlate with the clinical symptoms. So always, number one, ask the right questions, use your scales that have validation. So, I do use the biomarkers, but I don't use them often, honestly. And I could tell you that 9 out of 10 patients of mine are geriatric and they're screened.
There you go. Talking about pets, we're in a pet-friendly environment. This is a quick parenthesis here. You guys know that having a dog, it's have a higher effect size to protect you for a second heart attack better than aspirin. So I stick to the dog, I will stick to the dog anytime.
So that's another mild. So when the patient has a pet, likely they're to forget to feed the pet as well, or to take them out. And so the family doesn't realize that this is happening until they go visit them.
Poor Fido.
And yeah. Wow. And so it's a little bit of a problem. I know it's very therapeutic if they're depressed or anxious. But once they have dementia, it really becomes a problem of cleanliness and, them tripping over the pet or something like that.
And in terms of mentioning instruments and tools, you mentioned PHQ-9s and GAT7 and MOCA. What other tools, or at least testing or dimensions of cognition, you're looking for in a good test that you can administer at the clinic?
So I'm looking to see what the percentage is of that patient maybe having changes in a very short period of time. MOCA has a differentiation of tests that have an MIS that can tell me that. But again, that's not for a primary care.
Okay.
I think that's more for a specialist, a neurologist, a geriatric psychiatrist, something like that, because it takes a while to administer and it has to be administered in the language that is primary to the patient. So that's really important. If the other day I did one in Portuguese, and the number was very different from the English one, and she was fluent in English.
Okay.
Mm-hmm.
Because you revert to your primary language. And some people say, well, I don't even know what my primary language is. Well, in the language that you count your money.
Very good. And by the way, that's a good point, because I mean, in psychometrics, we use different instruments.
Mm-hmm.
And I have had some of my students asking me, no, we get that scale or that instrument and we just translate. Say, no, it doesn't work that way, because there's a ethnic cultural experience
Yes.
to express symptoms of these different disorders.
Correct.
Not necessarily the translation, it can be literally and figuratively lost in translation. So hence the importance to have not only the right instrument, but the right instrument for the patient in their native language.
Yeah. I always do the instrument myself. I don't let the MA or the students do it, just because if the primary care is trusting me enough to refer a patient to me, then I want to be able to make the right diagnosis and treatment plan and be able to work with that primary care. I don't want somebody that, maybe is in a hurry, maybe doesn't know the language perfectly, so that also you have to think about when you're referring a patient to a neurologist or a geriatric psych provider.
Yeah. Fair enough. And then you got the different tools. You have ones that are more, again, very kind of less sensitive than others. At your level, you're using the most sensitive, more specific tools that you can tease out a probably executive functioning that is not working well, or a Stoop test or whatever that might be. Let's say different specific cognitive dimensions. Now, primary care, we need to have something, let's say, more generic, or more sensitive, that can catch and say, there's something wrong here. Let me address the physiological aspect, the primary disorder. Let me address the diabetes or the hypertension or the heart disease or the benzos that are overprescribed, and then go into, okay, now we have it to this point, it's not getting better. We need to go into more specialized tool and knowledge and training, that in the case of you, that again, psychiatry and geriatric psychiatry, you need to have these specialized training. But at the beginning, yes, some of these, let's say, more sensitive tools that we can capture at the population level. So if I heard you well, we have these days Cologuard, and everyone in middle age 45 plus should be tested. But in the same way, in this population, everyone working through the door should be tested, at least mandatory, at least once a year. And I see this a lot, but I also see this phenomenon in primary care. Check. Yes, I check. Well, my test take 3 minutes,
Yes.
2 minutes, 5 minutes. And are we really doing the right test, or we're just under diagnosis? Because I just read this statistic when we started, 1 in 5. So that's 20%, 25% of the population. And then when I go to these different practices, we do some statistics. Only 3% of your population, only 1% of your population. There's a disparity here. So in that sense, an aggressive screening could be part of the strategy to capture more patients. That at the end you say, I wish I see you before. You don't want to go to that point. You want to a portion that you can address it.
Yeah.
I just wanted to, Liz, did you turn on the chat? Does anyone in the audience have questions as well? I forgot to mention that as we were going along. There is a chat there. Liz, is it actually turned on?
Yes.
We have a Q&A.
All right. Are there any questions from anyone? Just as we continue, where are we at? 7:13 from a time point of view, Dr. Marcos?
I'm seeing here from one of the attendees, when a primary care physician suspect major or mild neurocognitive disorder, what clinical circumstances will prompt referral to a psychiatrist versus a neurologist? So where I should send you first?
It's really up to the it's not easy to find a geriatric psychiatrist, to be honest, and much less bilingual. So most primary care physicians send them to the neurologist, but neurologists have evolved in the last 10 years, and they do very specific things like neurology for headaches, neurology for movement disorder, neurology for this, neurology for that. So it's becoming more and more difficult to find a neurologist just for dementia. And so in the psychiatric training, what we are trained for dementia, not as much as geriatric psychiatry, but we are trained. And so the neurologist ends up referring to psychiatry then, because then if they are on benzos, for example, they won't do the taper. They will leave it up to the psychiatrist to do the taper. If they are on a Z medication for sleep, they will leave it up to us to try and make them sleep another way and not take them off the medication themselves.
Mm-hmm.
So again, some neurologists take a long time, and they do with movement disorders and seizures and, you know, this kind of thing. But when it's dementia, usually it's very hard to find one. Neurology for dementia, I work with one in Boca, and I'm in Miami. So it's that hard.
I have another question here, and we kind of touch upon this, but more into the imaging. So we have the instruments and tools that we use at the clinic, practice written digitalized tools. Then we have the imaging markers, and I have here someone in the audience talking about blood-based biomarkers, and if there's any that you like to use, or if even cost effective. What biomarkers you use for these dementias?
So, as I said before, I use the biomarkers as very last resort, and it's really to confirm a diagnosis. I don't like using the biomarkers because they are not FDA approved. It doesn't mean that they have Alzheimer's. It's only for Alzheimer's, right? And so it's a measurement of amyloid, and they do not mean anything unless you have a PET scan to correlate it with, a beta amyloid PET scan. So if I were a primary care physician, I would not worry about these things, because then once you order it, it's out there. And then what do? You're going to give them exactly the same thing, donepezil and Namenda.
And I have another question here, and we touch upon these. Mr. Grogan mentioned omega-3 fatty acids. We mentioned B12, and there's a bunch of supplements, dietary supplements, that claim to help with cognitive functioning. And I have here in the audience talking about essential mushroom blend, lion's mane, and I have heard about different mushroom blends, and even for PTSD and so, but that's another day, another story. What is your take on these different supplements that exist in the market?
There is some evidence with the lion's mane that there is some neuromodulation that occurs, but again, it's a supplement. It depends on who you're getting it from, how much is absorbed, You know, you're not getting it prescribed. So again, you really have to do your research on which you're going to recommend to the patient, because they're going to ask you. If you mention lion's mane, they're going to say, which one do you think? So like,
Yep.
for example, B12, I always recommend something that has methyl. Why? Because it absorbs better.
Yeah.
So, you know, you have to be ready. If you mention the lion's mane, you have to be ready to give them like the best absorption and why. Because at least my patients ask me.
Yeah, unfortunately, the $9 one versus the $31, you know, there might be a reason for that, right?
And so it's very important for the primary care to really focus on the diet and exercise, not only for blood pressure, diabetes, cholesterol, but also because if you're not moving, you're also not moving the blood in your brain. And so the more stagnant you are, the more you're sitting in your couch, equals dementia.
And hence, I like to say, in medicine, we don't have a silver bullet. So no, you take this, do that, and you're cured. That doesn't exist. We hope. My dad used to say, "Do you find it?" He said, "Why find that? The magic bullet." No, I haven't found it. It's a combination of healthy habits, lifestyle modification, family support when it does exist, and providing the right tools to the patients. And I'm going to give you this one here, because we haven't touched upon, but I'm a proponent that an informed, educated patient is a powerful patient. Because now they start taking decisions in the daily life that end up changing their behavior, or that change in behavior impacts their health directly. So what are some of these recommendations in terms of patient education? What pieces of information you provide to the patient to let them know so they recognize, understand better their condition?
So I do give them a pamphlet of information and disease stages. I recommend diets. Special diets like Mediterranean diet, for example. Exercise, I go with, you know, what cardiologists recommend, 150 minutes a week. The important thing is to move, not to move fast, just move. Not walking your dog, but I mean, like, move. The other thing is I want them to focus on engagement, right? So a lot of times I send them to Tai Chi class or chair yoga classes. More importantly, because they socialize in the class with other people, and it becomes a nice event to go and exercise. The more balance you have, the better you age in place. And so aging in place is important for them, because the moment you put them in your house, or you move them to a nursing home, that's it. That's the end. So I try to get them engaged. There are free classes in every public library of chair yoga and Tai Chi. And it makes them engage. It makes them make the reservation for the class and all of these things. So I think socializing is very important. There's research, the blue zones, they age to 100 with good minds because they eat healthy and they move and they socialize.
They socialize. So social determinants of health. Again, I was reading not long ago that the best or from the things that you can add or subtract from your life to increase longevity, living in isolation takes away 20 years. 20 years. It's followed by oral health, 10 years. We're talking 20 years. I have another question, interesting question here. And you were talking about Mediterranean diet, then we have the keto diets. As of lately, there's being a buzz out there with creatine monohydrate that usually is being used for muscle building, sports performance, but latest studies suggest that certain amounts seems to help cognitive performance. Have you experimented or
I
Have
have
you,
not. I have not,
no?
just because remember that most of these, so you're talking about maybe prevention of with a younger patient. But once they are 65, most patients are on more than 3 medications. Drug-drug interactions, absorptions, the liver is not the same, hepatocytes are older. And so we need to be very careful about the supplements that we're feeding the patients. So, and that we recommend. So I would not recommend creatine in an older person, but there's a lot of people that take it and they feel great, you know. There's also some evidence around lithium. Yes, lithium also has been used. I just, you know, I've read a lot about the lithium because that's an easy one. That's something that I know how to use it. And I have 2 patients on lithium and it's been a game changer. They re-engage, they laugh again. And it's a very low dose of lithium. It's 150. So it's making a difference.
Okay. I read about lithium. One of my residents was presenting to Journal Club, by the way, on some of these translational research experiments looking into the interactions in Alzheimer's. Interestingly, again, it's a trace mineral. We use it. You know, it's not a medication. Well, it's a medication when it's prescribed and for that purpose, but it's a trace element that we need for normal function. So goes along with the same dynamics of B12. If you don't have that nutrient and it's missing, whether it's a diet or you're not eating or you're absorbing it, that can impact your cognitive functioning
for sure
in a way.
The other thing that is being used, Medicare doesn't pay for it, but a lot of people are paying out of pocket, is the transcranial magnetic stimulation for mild cognitive impairment. So there is increase in dopamine, increase in glucose in your brain, and the agility tends to improve and sleep gets better. And so I have used it on some of my patients and there has been some improvement and has helped them in staying in their own apartment for a little bit longer.
Okay. Yeah. Then again, as you mentioned, sleep is one of those things that if there's something in your life, whether it's nutritional, social, it gets affected. But when you start doing these changes, it's one of the first things that goes back on track. You say, you know, doctor, I'm sleeping better. Oh, that's a good sign. We're going to the right. So we need to ask those questions definitely at the primary care level. And I think I have time for one more question. And here's I have someone, is it reasonable to continue Aricept or better to stop it due to ineffectivity? Thank you.
So I would say to that, it's better to continue because many times the family says, I don't see an improvement. And it's not an improvement that you're going to see. It is a continued decline in the patient. And so when you take it away, they have an acute step-like decline. And they quickly say, we need to get back on the medication.
Yeah.
So it is important to have the Aricept, increase it to 10, and add the Namenda, 2 different mechanisms of decreasing the progression of the illness, not curing it, not doing away with the amyloid like Leqembi and the others. This is just to put a pause on the progression of the illness. And so it's important as primary care to go ahead and start it, because even if you refer them, then they'll take care of the meds, neurology or psychiatry, but start it. It's super important to start it.
Mr. Grogan, I think this being an enlightening conversation, and I would like to ask way more questions, but we need to allow Dr. Junquera to rest a little bit, but go ahead.
I have the one gem question that we always should ask, and that is, Dr. Junquera, what question did we not ask you today that we should have asked you based on the subject and the topic?
So I think that there's a lot of resources that primary care can give the family and the patients that they don't need to wait to come to a specialist to go ahead and notice, right? So sometimes a family comes and it's late and they already have Alzheimer's dementia or vascular dementia. The Alzheimer's Association has many, many resources that the patients and the families can use. There is caregiver groups that are on Zoom. There are Meals on Wheels that deliver food to the patients. And all they have to do is go online and figure this out, the family members, right? I think it's a great support system for the families. And I think the primary care physician can for sure do that. I see many, many patients that come to me and they have not gotten any resources.
Right.
Alliance for the elder aging, also a good resource. So
It's a great segue. I'm glad that you mentioned that. A lot of the audience here and the fact that we're recording this and it'll go out very soon after we edit out myself in some parts, of course, is we've just developed a new tool. We call it the QHSLab, and it really does align with everything that you've said. It's a universal population screening tool, once a year annual wellness visit type of encounter. And it takes into account the quality of life, the sleep, the pain, the satisfaction, positive affectivity, and your PHQ-9 and GAD-7, some other psychiatric vital signs to identify mood disorders and maybe some anger and mania and substance abuse and tobacco use or misuse, alcohol misuse.
oh yes, that's
Also, sorry.
I forgot that one. That one's so important. So it often you don't have time as a primary care, as any real physician and a follow-up to ask, hey, are you drinking? How much are you drinking? So more than 14 drinks a week is not a good thing, and there's going to be a mix, right? And so it becomes a little bit of a problem when you have a patient that has vascular or Alzheimer's and they're drinking.
Mm-hmm.
So
Yeah.
sorry, go ahead.
That's the great thing about this instrument. It picks up on the falls risk that's required once a year and social determinants of health, housing, environment, food security, personal safety. But it also goes into the mini-cog type of instruments as well. So the primary care doctor is getting these initial screening, validated tools all in one battery. With then clinical decision support, like you said, what are the cutoff levels for referral or to consider referral and why? So in the email that will be sent out to everyone with the recording of this, there'll also be a link that you can set up a time one-on-one to talk more and actually see this instrument in use. So we're really excited. We are a research-based organization, real-world research. And so we'll be looking to publish in this area once we get enough data, but we're already off to a good start with Dr. Marcos, close to 100 odd, records where a psychiatrist has actually looked at the record as well. So anyone interested, you'll get an email with a recording of this video, and you'll also get a link there to set up a time to have a conversation one-on-one about your practice. Dr. Junquera, it's been very enjoyable. I love this format, this kind of podcast format, questions, we get to talk. It's not a didactic presentation. So thanks for doing this. As always, Dr. Marcos, thanks for leading and moderating the session. And everyone else, this QHS, primary care, optimizing primary care. Dr. Junquera?
I have a question. So this tool, can we bill for it?
Yes, you can. I mean, in the fee-for-service world of primary care, there's a number of billable elements, and it's all done in one particular. You can bill for PHQs and GD. There's some just simple billing, and there's more complex as when you get the time and the calculations, the scoring, the patient feedback. So yes, there's a billable component to it. In the capitated world, there's risk adjustment factors that can be achieved when you actually do the right diagnosis. And it needs a psychiatrist, it needs a specialist involved, but that helps that capitated population to, you got to do it anyway. 100% of patients need to be screened every year. If you can catch patients that might not have been caught, then that does affect your capitation models as well. So yeah, it's got multiple uses. First things first, patient care, meeting guidelines, but of course there is some reimbursement opportunities and for the specialist as well. You have a lot of tools that you already use, things like our digital medicine platform. It certainly helps specialists more efficiently capture data as well. So yeah.
Okay, thank you.
I just got a text. I just want to make sure it wasn't another question, but yeah, okay. So yeah, look out for that email. Thanks again, Doctor. Thank you, everyone that's
Thank you.
joined. And we look forward to the next webinar in the QHS Optimizing Primary Care series. Have a great evening.
Thank you. Bye-bye.
All right, stop recording. Where is that? All right, Marcos, we'll drop off now. Talk to you soon.
See you tomorrow.
Yeah.
Bye.